Walking is a wanted activity of everyday life. It is a type of locomotion. Locomotion is the act of moving from place to place by means of one's own mechanisms or power. It is a result of our body levers propelling the body in a specific direction. The locomotion is accomplished by alternating actions of the two lower extremities, the natural sway of the upper extremities, and the stabilization of the core. Walking can be seen as a pendulum-like movement because of one's leg will start in a specific motion and end in the same position. As one leg is swinging forward and transitioning to the next phase, the other leg is supporting the body. This type of movement has three types of phasing: starting phase, swing phase, and support phase.
Starting phase position would be in anatomical position with the hand and forearm immediately rotated 180 degrees at the glenohumeral joint.
When you begin to walk, you start the swing phase with one lower extremity. It will start with the right leg moving forward. The start of the swing phase is the moment the toe goes out of contact with the ground surface and ends with the foot striking the ground. In this phase, there is a pelvic rotation, pelvic tilt, hip flexion, knee flexion, extension, dorsiflexion, and flexion of the left shoulder. The opposite arm swings with the extended leg movement.
Right after the swing phase is the support phase. This phase begins with the foot strike at the end of the swing phase and right before the toe loses contact with the ground to start another swing phase. In this phase, you will have the pelvic rotation and tilt, hip extension and knee flexion and extension, plantar flexion, dorsiflexion, hyperextension of the metatarsal phalangeal joints, and shoulder extension. Between the two phases, the support phase makes up 60% while the swing phase is 40%.
This is an overview of the phases broken down. The first part of the body that we're going to look at is the lower extremities of the swinging phase. One thing to remember: while one leg is in the swinging phase, the other leg is in the supporting phase later described. These movements happen in the sagittal plane along the bilateral axis. Within this phase, there are two minor phases: acceleration and deceleration. The first half of the swing phase is the acceleration and the second half is deceleration. The first joint that we are going to focus on is the hip joint. The pelvis is moving in two ways: tilting and rotating. While walking, when you start the swinging phase with your right leg, the right pelvic bone will tilt posteriorly to the concentrically contracting muscles semispinalis, rotators, multifidus, and external oblique. The range of motion for the tilt is about 4 degrees. The pelvic bone will also tilt laterally towards the supporting left pelvic bone about 4 degrees as well to prevent excessive trunk rotation and lengthening the stride of the step. With these muscles being the agonists in this motion of this phase, there are also supporting muscles. The psoas and quadratus lumborum help the pelvic bone from rotating or tilting too much. With too much tilt or rotation, your alignment is at risk. Another aspect you have to look at is gravity. Gravity is constantly pulling down on your body, and if we do not have the gluteus medius or minimus, our legs would laterally fall away from our body. Those two muscles are concentrically contracting to make sure our legs do not move laterally, just anteriorly and posteriorly. At the hip joint, where the pelvic bone and the femur meet, there are more prime movers that assist in walking properly. In the swinging phase, that joint experiences only flexion until the next phase in walking. With the flexion at the hip joint, the leg is able to move in a forward manner. The prime mover and force-producing muscle is the concentrically contracting iliopsis. Since the iliopsis muscle group is concentrically contracting, the hamstring muscle group is eccentrically contracting. While this is the prime mover, there are a handful of muscles that assist in the flexion of the hip joint. They include the rectus femoris, sartorius, gracilis, adductor longus, pectineus, and the short head of the biceps femoris. The range of motion of the hip joint in the swinging phase is 35 to 46 degrees of flexion. The next joint in the lower extremity during the swinging phase is the knee joint. This joint will experience flexion for the first half, which is also a part of acceleration, and extension through the rest for the deceleration. There are three muscles that are the agonists of knee flexion, and those are the semitendinosus, semimembranosus, and biceps femoris. The two weakest sisters are the sartorius and the gracilis. The average range of motion is 35 to 64 degrees flexion. These muscles are concentric contractions, while the quadriceps is eccentric contractions until you reach the halfway point and roll switch. When you hit the halfway point, the knee begins to extend. Now the quadriceps are concentrically contracting while the hamstrings are eccentrically contracting. The prime mover for extension of the knee is the rectus femoris. As the knee is extending, the range of motion will decrease in degrees to around the 8-degree era. During the swinging phase, the gastrocnemius and soleus complex are isometrically contracting to make sure that there is no dorsiflexion or plantar flexion so that the foot stays in a neutral position and is prepared for the beginning phases of the supporting phase where they have more of a role.
That completes the swinging phase. While the right leg is in the swinging phase, the left leg is in the supporting phase. There are 3 different phases within this phase. These consist of the heel strike, mid stance, and toe off. When you are completing the swinging phase, as soon as your heel makes contact with the ground, the support phase begins. When the heel strikes the ground, the ankle joint is in neutral position. The knee is flexed at about 8 to 15 degrees with the body weight behind the knee, and the hip joint is flexed as well at about 35 degrees. All of the same types of contractions and muscle groups are being used in the same way when it comes to the knee and hip flexion. After the heel strike, you transfer into the mid stance, the second phase of the supporting phase. The ankle will be in dorsiflex at about 16 to 12 degrees. This is where the gastrocnemius and soleus really come into effect. Both of these muscles are essentially contracting to control the dorsiflexion so that the body can continue to move forward easily. During the mid stance, the knee becomes extended while the hip is at a neutral position. This last stage of the support phase is the toe-off stage. The ankle goes into plantar flexion at about 7 to 12 degrees. This is where the knee starts to flex again to 15 degrees to 1. Make sure that the foot clears the ground when it swings forward, and 2. To begin the swinging phase again, the hip is extended to 6 degrees. Right as the toe leaves the surface of the ground, the swinging phase discussed earlier starts again. Both legs go through these phases over and over again until the patient stops walking. While the right leg is swinging forward, naturally the left arm swings forward and vice versa. To prevent the arms from hitting the body while swinging, the deltoid is a prime mover of the glenohumeral joint. Its main job is abduction of the arm away from the body. The middle portion of the deltoid is always concentrically contracting. As the arm swings forward into flexion in the sagittal plane, the anterior deltoid is concentrically contracting at 12 degrees, while the posterior deltoid is eccentrically contracting. As it swings backwards into the extension at about 14 degrees, the posterior is concentric and the anterior is eccentric. At the acromioclavicular joint, the pectoralis major assists in flexion of the shoulder up to 60 degrees. While the arm is swinging forward, the elbow goes into flexion. The prime movers of flexion of the elbow are concentric contractions of the bicep brachii, brachialis, and brachioradialis. It will flex to a max of 15 degrees. As the shoulder swings into extension, the elbow extends to 4 degrees by concentrically contracting anconeus and triceps brachii.
Here's a quick overview of the leg muscles being used.
There are many factors that we must look at that affect walking. Walking is characterized by the transition of the body weight and center of gravity. This happens by the pendulum actions of the lower extremities during the swinging and supporting phases. Some forces that we must be aware of are the forces of the body weight, normal reactions, friction, air resistance, internal muscles, and the direction and interaction of all these forces acting together. Inertia is one factor that has to be overcome with every step taken. To do this, you have to constantly go back and forth with accelerating and decelerating in the leg speed. Another inertia factor is that the greater the body weight, the greater the inertia is to overcome. Anytime the leg moves past the anterior margin, your equilibrium is at risk, and gravity really kicks in by causing a downward force to try and bring your equilibrium down to nothing. As soon as the swinging leg strikes the ground, the equilibrium problem fades away as more of the foot makes contact with the ground until the other foot leaves the ground and the process starts all over. While one leg is in the midst of swinging, the trunk becomes part of the supporting muscles so that you do not fall over sideways. There are several important principles that involve the factors just discussed to consider when doing a walking gait. The first principle is to understand that the body at rest will stay at rest until acted upon by a force. The force that causes a walking motion is the resistance the ground produces while the lower extremities are extending and pushing off. On the other side, a body in motion will remain in motion until acted upon by a force as well. While walking, Your trunk tends to rotate with the swinging leg. The force applied to the trunk are the muscles on the supporting leg side contracting to get ready for its turn in the swinging phase. There are certain rotational movements that cause translator movements by a lever. When the foot is in contact with the ground in the support phase, the hip joint is rotating in the swinging phase. The rotations cause the same joints to experience less power.
Okay.
There are forces applied diagonally which can contain horizontal and vertical components. The ground applies the vertical components to offset gravity. The horizontal components make sure there is forward motion of the trunk and foot strike, and that the forward motion is produced at heel off and toe off stages to support phase. To increase the speed of your walk, you must do one of two things. You either increase the stride length or the stride rate or both. The speed is also dependent on the magnitude of the pushing force as well as the direction it is intended to go in. The efficiency of locomotion is partially dependent on friction from the ground as well as the ground reaction force provided by the surface. Not only is the efficiency related to the forces, but it also depends on timing in reference with the length of the limbs moving.
While walking, a base of support is always needed. That is why most people believe that walking is known as the loss and recovery of balance all in one. Not only is a base of support always needed, but the size of your foot can determine how much stability you have. The bigger the support base, the more stability.
According to Ranchos Los Amigos, there are several factors that affect a walking gait. The first factor has to do with the pathological gait. This includes pain, disease, injury, and congenital deformity. Some of the most common problems under this category are neuromuscular disease, spinal cord injuries, and brain injuries. You also have the factors of age, obesity, balance, and vestibular problems. As you get older, so do your muscles. They tend to get a bit weaker and you lose some flexibility. While this happens, your balance becomes at risk. Usually with older people, they tend to shorten their strides so that there is less of that balance uncertainty time where one foot is in the swinging phase. With shorter strides, you have more time in double support phase where both feet are touching the ground at the same time. You can also help with balance by using a cane or, if it is extremely bad, a walker. With obesity, the extra weight adds more power and stress on the joints of the lower limbs. There is also a greater significance of extra horizontal movement of the lower limbs due to having so much extra weight. Those that are obese will have shorter strides and longer periods of the double support phase along with the older people. Those that are in the pathological category of walking gait need an exact diagnosis so that the therapist knows exactly what needs to be done. With neuromuscular diseases, the muscles become very weak and do not function like they are supposed to. Depending on their size, the weight makes it even harder to be mobile. There are variations of improper ways to walk. Some would include a propulsive gait, where you hang your head and neck forward to throw off your equilibrium. Scissor gait, where your legs are bent and when you walk, your knees hit or cross over one another. Spastic gait, where your foot is being dragged behind you. Steppage gait, where everything, including your foot, is pointing downwards towards the ground and causing excessive motion of a hip and a knee to walk without dragging the foot. And lastly, a waddling gait, where you literally look like you're walking like a duck. Even though there are so many errors, there are many ways to fix it. The first thing that needs to happen is for encouragement of family members or close people to help the one with a walking gait problem to really work on the fundamentals. Tell them that they can be independent. When doing a lot of walking, walk slowly so that losing your balance is not an issue and you do not have to worry about catching up with others walking ahead of you. You can always use a cane or a walker depending on how severe the walking gait is. Lastly, you can go to the therapist and get treatment to help improve some of the problems you have with walking. For those that have the scissor gait problem, leg braces and in-shoe splints will really help prevent your legs from giving in. There are also some medications that can help with the muscle spasms that can cause this kind of gait to happen. For a spastic gait, exercise to strengthen all the leg and hip muscles. This is going to be the most beneficial for you. You can use a cane or walker to begin with until your gait improves. For the steppage gait, fatigue is your biggest enemy. To exercise and get your stamina up is going to be beneficial, as well as taking breaks when walking a long distance. There are leg and shoe braces that can help with the drop foot as well as E-stim. The E-stim will contract the anterior tibialis muscle for you to teach the muscle to contract again. If all else fails, go to the doctor and get a prescription to go to a therapist where they have access to gait walk equipment as well as the balance equipment. A few tips to watch out for are the alignment of your lower limbs to prevent strains and other injuries, unnecessary lateral movements, normal flexibility of the joints, and properly functioning reflexes.
If you see any abnormality in one of those, try to make adjustments. There is always an answer to help improve, so go out and find it.